Professor T. Choudhury, sir. Professor T. Choudhury, sir, is the Professor of Department of Obstetrics and Gynecology, BADM. He is the former President of OGSB, Suffolk, and BCPS, former Vice President of AFOG, President of the Fertility and Sterility Society of Bangladesh. He is the recipient of Shadhinata Padak, the highest national award from Bangladesh government, and Gorkha Dakhin Bahu Medal from Nepal. He is the teacher of teachers, and may I request Professor T. Choudhury, sir, to please come up in the podium and take his seat. Thank you. With the permission of Professor T. Choudhury, sir, I am resuming the session. Our keynote speaker for this session is none but Professor Sir Sabaratnam Arulkumaran. Professor Arulkumaran does not need any introduction. He is the past president of FIGO, past president of RCOG, past president of the British Medical Association, and currently he is working as the Professor Emeritus of Obstetrics and Gynecology, St. George's University of London. And he will be speaking on maternal collapse. So may I request Professor Sir Arulkumaran, who has to make an early wake up because it's 6:30 a.m. in London, to please resume his talk. Sir. Sir, you can resume. Sir Arulkumaran, can you hear us?
I can't hear anything.
Sir, you can resume your talk. You can resume your talk, sir.
Sir, can you hear?
Yeah, okay, now I can hear, but before that I couldn't hear.
Okay. Sir, you are kindly requested to share your presentation and give the presentation.
Okay. Good morning, and thank you very much for inviting me for this conference. My best wishes to Professor T.A. Choudhury and the co-chairs and also the guests. So my topic today is on maternal collapse. So I have taken most of the material from this Green Top guideline by the Royal College on maternal collapse in pregnancy and the Paparium. The summary of the Royal College guidelines can result from a number of causes. A systematic approach should be taken to identify the case, what the problem is. An obstetric modified early warning score chart should be used for early recognition of the woman who is becoming critically ill, because a woman gets critically ill and then suddenly collapses. In causes of collapse assumed to be due to anaphylaxis, mast cell tryptase levels can be useful in confirming the diagnosis. It is essential that anyone involved in the resuscitation of women is aware of the physiological differences. This includes pre-hospital clinicians, paramedics, and emergency medicine department staff, And I will talk a little bit about the physiological differences. Aortic cable compression significantly reduces the cardiac output from 20 weeks of gestation because of the obstruction to the aorta and the inferior vena cava, and the efficacy of the chest compression during resuscitation also is hindered by a pregnant uterus over 20 weeks. Changes in lung function, diaphragmatic splinting, and increased oxygen consumption make pregnant women become hypoxic more readily and make the ventilation more difficult. And difficult intubation is more likely in pregnancy. And pregnant women are at increased risk of aspiration because their gastroesophageal sphincter is relaxed due to the progestogen effect. And manage arrhythmias as usual, recognizing that they may be refractory to treatment. So it's a difficult issue to manage. Supplemental higher flow oxygen should be administered as soon as possible and to counteract rapid deoxygenation. So you have to give oxygen. Bag and mask ventilation or insertion of a simple supraglottic airway should be undertaken until intubation can be achieved. If the airway is clear and there is no breathing, chest compression should be commenced immediately. 2 wide-bore cannula, ideally 14 gauge or orange cannula, or gray or 16 gauge cannula should be inserted, because with the 14 gauge, you can give 240 mL of saline per minute, and with 16 gauge, 180 mL. So you have to use 14 or 16 gauge cannula as soon as possible. And if peripheral venous access is not possible, early consideration of central venous access, either through the jugular vein or interosseous access or venous cut down should be considered. There should be an aggressive approach to volume replacement. Caution should be exercised in the context of preeclampsia, eclampsia, where you can flood the lungs and cause respiratory problems with too much fluid. Abdominal ultrasound by a skilled operator can assist in the diagnosis of concealed hemorrhage. And here you have to tilt the woman at 45 degrees so the blood can collect in the pelvis and you can do an ultrasound. If you keep her horizontal, then the paracolic gutter will be occupied by blood and you won't be able to see any blood accumulated intra-abdominally. So the definition of collapse is inadequate cerebral perfusion. Essentially, it means loss of consciousness due to one of these 4 reasons. Inadequate cerebral perfusion, inadequate cerebral oxygenation. So the perfusion might be okay, but the oxygenation is affected. Abnormal cerebral electrical activity like eclampsia, hemorrhage in the brain, epilepsy, and so on. So that is another possibility. And major brainstem dysfunction, either due to some adverse illicit drug or hypoglycemia or some other metabolic problem. So we have to think about cerebral perfusion, cerebral oxygenation, electrical activity, and brain dysfunction. One has to also distinguish between simple faint and impending death from a catastrophic pathological insult. In a simple faint, patient will have some prodromal features. A pregnant mother might stand straight and she might feel a little bit giddy. She'll start sweating, her eyes will be rolling, and then she will coil like a spring and fall down. Whereas a catastrophic pathological event like pulmonary embolism or a myocardial infarction, they are vertical and then they horizontally go flat by 90 degrees. So you can distinguish very easily. And the pulse will be feeble, but it'll be okay in a simple faint. Whereas catastrophic pathological insult, you might not feel a pulse after a couple of minutes. Now, the initial assessment has to be very important. So first we have to assess the state of consciousness, whether the patient is conscious, how fast he or she is conscious, and in a pregnant mother we are talking about she, whether she is able to respond to verbal commands, to painful stimulus, and so on. Then immediately, if she is unconscious, then we know she has collapsed. So we had to start the ABC process of basic life support. Airway, make sure there are no dentures or secretions in the oro and nasopharynx, and there's breathing has to be checked. by movement of the chest, listening to the nostril, and circulation by checking the carotid pulse. So you have to check the airway breathing and circulation and start acting. So the action is initially by checking the responsiveness, by shouting and shaking the patient, and then open the airway by tilting the head backwards with the chin lift so that the airway becomes almost like a straight line, and check the breathing. As I mentioned, look, listen, and feel. And if there are no breathing sounds or chest valve movements, then you have to give 2 effective breaths. If you have an umbu bag and a mask, you can give it through that. And you have to assess the signs of circulation on the carotid pulse. And if there is no circulation, you have to start compressing the chest. Now, when we compress the chest, it has to go by 1/3 the depth of the chest, at least 1/3. If you more than that, you might fracture the rib, but 1/3 chest, and it'll compress the heart. But the cardiac output is usually 1/3 of the normal cardiac output with that. That is why you have to pump more number of times, at least 100 times per minute compared to standard 68, 70 pulse rate. So you have to pump more number of times. And ventilation, of course, when you blow into the lungs, it'll occupy the whole lung. So the ratio can be 15:2. And if they start fibrillating, then you have to think about defibrillation by giving shocks. You have to get back to normal rhythm. But if the circulation is present, if the carotid pulse is present, and she's not breathing, then of course, suddenly the circulation might stop. So you have to keep on checking the circulation and continue the breathing. So let us look at the common causes. Primary cerebral event that leads to loss of consciousness can be epileptic fit, eclampsia, hypoglycemia, profound hypoxia, intracerebral bleed, cerebral infarction, anesthetic or analgesic drug. These all affect the brain directly because of abnormal electrical activity, abnormal metabolic activity, or bleeding and causing vasospasm, and anesthetic analgesic drugs, immediate effect on the brainstem functions. So that is primary cerebral event. The second, you can divide into cardiovascular as pump problem as number 8. And it can be due to arrhythmia. So if the person is mitral stenosis, the person has arrhythmia, not enough blood goes to the brain, and they can collapse. Secondly, it can be a pump problem due to myocardial infarction. That is common in the UK now because the main cause of death in the UK, maternal deaths, is cardiac disease, not congenital or rheumatic, but acquired heart disease because mothers are getting pregnant, elderly, obese, diabetic, and hypertensive. So this is a major problem, and myocardial infarction can compound problem. Cardiomyopathy in the last few months or soon after delivery, they can go into failure. If you do a chest x-ray, plain chest x-ray, the heart shadow will occupy more than half the field, a dilated heart, and if you do an echocardiogram, the ejection system is more than 30%. So they might need some cardiac assist device to support, otherwise failure. So they can collapse if there is not enough oxygen due to the cardiomyopathy. The second cardiac issue or cardiovascular issue is there is a block in the circulation or leak in the circulation. So the block is in the form of pulmonary embolism, which is on the right heart. So the pulmonary trunk might be blocked or massive in circulating volume compared to relative decrease in shock. This is absolute decrease. So you keep on bleeding like a major hemorrhage. It can be antepartum hemorrhage, postpartum hemorrhage, or a rare cause like a splenic artery aneurysm rupture. And the third is actually a relative shift of pooling of blood. That can happen when there is a simple faint, of course, which is recovered very easily, but it's sepsis. The meta-arteriolar sphincters are damaged in sepsis, and there's a filling of the capillary beds, and the blood starts pooling in the periphery, but nothing in the effective circulation. Same thing happened with anaphylaxis and amniotic fluid embolism. This can happen. Amniotic fluid embolism, multiple mechanisms, like a right pulmonary artery spasm, which causes raised right side pressure, but also left ventricular dysfunction can happen with pulmonary amniotic fluid embolism. So that's a relative problem of shift or pooling. So if you put it diagrammatically, you can think of eclampsia, intracranial hemorrhage, and you can add epilepsy on top. So that is the one which causes the problem to the brain directly, or can be illicit drugs which you have inadvertently, or is taking illicit drugs intravenously that can affect the brain. Then anaphylaxis causes bronchospasm severely, and you should be able to treat that. Pulmonary embolism, amniotic fluid embolism. Aortic dissection is unusual, but large amounts of blood can accumulate between the adventitia and the medial layer, and they can collapse. Cardiac causes arrhythmia, infarction, and cardiomyopathy, as we mentioned. And drug problem like too much magnesium sulfate, so you have to give calcium gluconate to reverse it, local anesthetic, and illicit drugs. And hemorrhagic, very rare, is splenic artery aneurysm rupture, hepatic rupture in severe preeclampsia, and from the uterus, of course, antepartum, postpartum hemorrhage, and sepsis, one should not forget, can happen and cause collapse. So we'll take the common causes one by one. Hemorrhage, always consider that as a cause, because the commonest cause of pregnant mother collapsing is hemorrhage. Always exclude hemorrhage in all cases of maternal collapse. It can be antepartum hemorrhage or postpartum hemorrhage, and postpartum hemorrhage can be concealed with blood accumulating in the uterus. Antepartum hemorrhage, in abruptio placentae, large amount of blood can accumulate retroplacentally, and there will be very little blood sometimes being revealed, so the signs will be out of proportion to the amount of blood you see, and you have to give her enough blood so that she doesn't cause vasospasm of various organs and organ damage. Uterine rupture is a cause for postpartum hemorrhage. Hepatic rupture, so these are rare cases. One should be identified other than the standard APH and PPH. Now, in a very rare circumstances, aneurysm of the splenic artery can rupture. And there could be arteriovenous malformations which can rupture or can be within the uterus, causing persistent postpartum hemorrhage. And I mentioned about aortic dissection. There are three conditions we should remember and lose more blood than we can see. One is fracture femur, the other one is aortic dissection, and the third one is abruptio placentae. In these three conditions, the blood loss is massive and you don't really see it, and suddenly the woman can collapse. Now it is postpartum hemorrhage. As usual, we have to think about the 4 T's: tone, tears, tissue, and thrombin. Antepartum hemorrhage, we have to think of abruption and previa. And some women can have antepartum followed by postpartum, especially if there's placenta accreta, spectrum disorders, and they can cause disseminated intravascular coagulopathy. It is good to have a mnemonic or some way of acting, and we use hemostasis or postpartum uterine atony. Help assess patient, ecbolics, which is additional oxytocin, massage uterus, oxytocin, and tranexamic acid. And then, of course, if the medical part doesn't work, then you go into the stasis part. You put a shock garment and shift to the theater, tamponade test, which is therapeutic and prognostic, apply compression sutures, and systemic devascularization, it doesn't work, and interventional radiology to embolize the internal iliac and the uterine, and nothing works, then subtotal or total hysterectomy. So this is a mnemonic, but now the WHO is proposing an emotive approach for postpartum hemorrhage due to atony, which is early detection, massage, the uterotonics, which is like oxytocin, tranexamic acid, IV fluids, and examination. Emotive care bundle can replace this. Now we have to assess the hemorrhage, how much shock it has caused. If it is 15%, there is a peripheral shutdown. So there is a vascular constriction in the skin and the muscles, so they feel pale, sweaty, and they are weak. 30% blood loss, so still they maintain the blood pressure. 30% blood loss, there is a tachycardia, so the heart, which is 80 to 90, goes to 110, 120. Tachypnea, decreased blood pressure, altered mental status, and decreased urinary output. So this is a visceral shutdown, so that means the blood flow to the kidneys affected, so they have decreased urinary output. Blood flow through the coronary is affected, so it can have a tachycardia and decreased blood pressure, and to the brain, altered mental status. If it is 45%, she goes into severe shock. That is where she completely collapses. The heart rate is usually over 120. There's anuria, there's decreased blood pressure, loss of consciousness, and difficult to feel peripheral pulses. And there's a sudden down. And if you are monitoring a patient, suddenly you get some arrhythmia and suddenly heart will stop. And easy way of looking at it is, which is 0.7 to 0.9 in a pregnant mother. If it goes to 1.4, almost double, then that means she's lost. If it is 30% increase, probably she's in moderate shock. And rule of 30 is similar. The pulse hematocrit drops by 30, then probably she has lost 30% of her blood volume. Now, once you have observed this 30% loss of blood volume with increase in pulse rate, drop of blood pressure, urinary output, and hematocrit, then she will go into severe shock. And once she goes into severe shock, then the chance of survival starts reducing, and one has to really start engaging and stopping the bleeding immediately and resuscitating the patient immediately. Now, if she gets a cardiopulmonary arrest, which occurs really rarely, 1 in 30,000 pregnancy, the chance of survival, if you don't resuscitate the patient well, drops by 10% each minute. So by 5 minutes, if you haven't resuscitated and got the heart going, there's a 50% chance of mortality. If 7 minutes you take to resuscitate, it's 70%. So whoever is by the side of the woman is the best person to start the heart by chest compression. So early resuscitation helps a lot. Now, when it comes to resuscitation policy, we can think about 4 things. One is a closed chest massage, which is a conventional treatment like ABC, airway breathing and circulation. Second is perimortem cesarean section. If the uterus is more than 20 weeks, or certainly in the 3rd trimester, it'll prevent the venous return and good cardiac output. And thirdly, open cardiac massage, which we don't take in pregnancy so much, unless there's a trauma case where the abdomen has to be opened or the thorax has to be opened, then we do open. Otherwise, we rely mostly on closed chest massage. And finally, on cardiopulmonary bypass, which in cardiomyopathy it might be needed. So the number 3 and 4 are rare items, and I will not discuss that in this lecture today. So you start with basic life support, which is airway breathing, circulation. Advanced life support involves giving adrenaline to get the heart going, and also bicarbonate to neutralize, and vasoconstrictors if the blood pressure is not coming up. So you need an anesthetist or intensive care specialist to support you with the advanced life support. But we have to be present, because in obstetrics, we have special resuscitation measures like putting the woman on the side or pulling the uterus to a side to resuscitate. So the pregnant patients who have altered physiology compared to non-pregnant state, that's why the obstetrician or the midwife is important, because we know that cardiac output is increased by 20%, oxygen consumption is increased by 20%, and because of the displacement of diaphragm, cephaloid by the gravid uterus, there is decreased functional residual capacity of the lungs and decreases in lung compliance. Now, pregnant patients have altered physiology, not only due to the pushing of the uterus over the diaphragm, but their systemic vascular resistance is decreased by 20%. And uterine blood flow is increased by 10-fold, and physiology of anemia of pregnancy comes into play, and decreased buffering capacity because of the increased breathing and aortic cable compression. So these are special features which are not found in non-pregnant mothers. And even in pregnancy, the blood volume varies depending on whether she is just pregnant, 20 to 30 weeks. And once she goes into labor, some of the blood from the uterus gets pushed into the systemic circulation. The late first stage, more blood, as you could see on the green bars. And immediate postpartum, blood volume rises from anything from 5.5 to nearly 8.5 liters of blood. And this is a major problem, because if the woman has cardiac disease, she has lung failure in the late 2nd stage, immediate postpartum period. So they have to be monitored very carefully. This is a picture showing the aortic cable compression. On your left side is where she's lying on her back, and the inferior vena cava and the aorta are compressed. So the blood is taken back to the system by distended azygos veins. When she is tilted to the left, then the pressure on the inferior vena cava and the aorta are released, and those becomes very open, and the azygos vein collapses back to its normal size. So the trick is to make the gravid uterus to tilt to the left side. So the conventional treatment of closed chest massage needs a tilt of the uterus. Either you can put a cardiac wedge, which is on the right side. If you put it, the uterus will tilt. Or she can lie on her back and you can pull the uterus to the left side. And nowadays, pulling the uterus seems to be more preferred because cardiac compression are difficult in a semi-turned patient. So alternatively, you can put a human wedge. As you could see, if you apply compression on a lateral fashion or anterolateral fashion, it's not effective. The woman is on her back and it's much easier. But then instead of putting the wedge, you go to the left side and pull the uterus towards you so that the outer cable compression is released. So the slight modification is if you're going to use intubation, you have to use a cuffed endotracheal tube because the gastroesophageal reflex is not there. There is more reflux and acidic gastric fluid can come into the lung. So if you put a cuffed endotracheal tube, that can be avoided. You have to use a breathing bag and mask ventilation, and you have to give high flow supplementary oxygen because she needs 20% more oxygen because of the pregnancy. Thirdly, because of the shift of the uterus to the left, you have to make a lateral shift of 15 to 30 degrees. And in the absence of breathing despite clear air, compression should be commenced, and 2 wide bore cannula, as I mentioned, 14 and 16, and you have to give a fluid so that you can increase the blood volume. An aggressive approach to volume replacement. Drugs, same as non-pregnant. You have to give adrenaline bicarbonate, you have to do that. And energy, the same defibrillation energy should be used as in the non-pregnant patient. So the advanced life support algorithm says that you have to give a shock, which is 4 joules per kilogram. So you have to calculate. And the defibrillators now automatically tell you it's a shockable rhythm or not. And you can give the shock if it doesn't come back to normal rhythm. You have to start the cardiopulmonary resuscitation after 2 minutes. So you have to minimize interruption. You have to make sure the area is clear, and you have to really make what is necessary. So the same defibrillation energy should be used as in the non-pregnant woman, and there should be no alteration in algorithm of drugs or doses used in resuscitation counsel protocols. Common reversible cause of maternal cardiopulmonary arrest should be considered throughout the resuscitation process. So while you're resuscitating, you have to make sure what happened, why did she collapse, and what can I do more than resuscitation. Resuscitation effort should be continued until a decision is taken by the consultant obstetrician and anesthetist to discontinue resuscitation efforts. So if it becomes a hopeless situation, then at least 2 consultant obstetrician and anesthetist has to discuss and say, okay, we are going to stop because the pupils are dilated, she's not recovering, and so forth. The decision should be made in consensus with the cardiac arrest team. So if you have a cardiac arrest team, they will also say they have worked hard on the patient and she's not recovering. So the optimal management of maternal collapse should follow the resuscitation council guidelines using the ABCD approach with some modification for maternal physiology, in particular aortic cable compression. Maternal cardiac arrest occurs in the community setting. Basic life support should be administered and rapid transfer arranged. Manual displacement of the uterus to the left is effective in relieving aortic cable compression about 20 weeks gestation, and permits effective chest compression in the supine position. In case of major trauma, the spine should be protected with a spinal board before any CPR is applied. In the absence of a spinal board, manual displacement of the uterus should be used. So she lies flat, but you pull the uterus to the left. Intubation in an unconscious woman with a cuffed endotracheal tube should be performed immediately by an experienced anesthetist. So that's about the ABC and the general concepts. So we'll look at perimortem cesarean section. It was promoted by Katz in 1986, and is the word by Katz. unequivocally, if a pregnant woman suffers a cardiopulmonary arrest from any cause during the third trimester, a perimortem pulmonary resuscitation. So there are two advantages, but the main reason is you want to save the mother's life. So this is from the Royal College guideline about perimortem cesarean section. Within 4 minutes in women over 20 weeks gestation, there's no response to correctly perform CPR, or if resuscitation is continued beyond this, then perimortem cesarean section should be undertaken to assist maternal resuscitation. So there are two conditions. First is over 20 weeks, continue more than 4 minutes. Ideally, this should be achieved within 5 minutes of the collapse, and perimortem cesarean section should not be delayed by moving the woman. It should be performed where maternal collapse has occurred and resuscitation is taking place. So it might be in the antenatal ward, in the accident and emergency department, it can be in the theater, anywhere it can happen, and you have to do it there itself. The operator should use the incision, which will facilitate the most rapid access. This may be midline vertical or a suprapubic transverse incision. So because the woman is collapsed, you won't feel anything. You take a scalpel, just put the gloves only. There's no need to scrub and gown and all that. You just go ahead and deliver the baby and put some sutures to close the wound, and then you start resuscitating. The scalpel and the umbilical artery clamps alternated to ligature should be available on the resuscitation trolley in all areas where maternal collapse may occur, including the accident and emergency department. Now, as I mentioned, I will mention about open cardiac pulmonary bypass, which are rare events, but I'll go to take specific example. And pulmonary embolism is one of the commonest causes, which was identified in the UK as a major cause in 97 to 99. And the numbers at that time were 17. Some were before, some were after delivery. And it can happen for vaginal delivery or post-cesarean, although post-cesarean is commoner, but it can happen after vaginal delivery. So the diagnosis is by central chest pain, pleuritic pain. The woman will say on the back between the scapula, there's an area which is hurting her when she takes a deep breath. And it has come on with sudden onset. And if massive pulmonary embolism, she can collapse and cyanose. And you have to do an ECG and a pulse oximetry, which because oxygen saturation will be less than 92%. And ECG will show signs of right ventricular strain. So you can immediately put a pulse oximeter and an ECG on. And if possible, arrange a ventilation perfusion scan or a spiral CT to identify where the embolism is. Now, in terms of clinical signs and symptoms, tachypnea, dyspnea, difficulty, labored breathing, and pleuritic pain, and apprehension, cough, tachycardia, these are the common features on the cases of proven pulmonary embolism. So if she's rapidly breathing and dyspnea and tachycardia and so on, then it is obvious that could be. This is to show that there could be a right ventricular strain. Sometimes there could be a right bundle branch block as well. This is ventilation perfusion scan. You can see posteriorly on the left side, the apical area is blocked. Or you can do a CT scan, which will demonstrate the subtle embolus, as you could see here. The embolus is, that's the aorta, the pulmonary trunk coming and dividing, and there's a subtle embolus crossing across. So the treatment is immediate resuscitation. If she's oxygen saturation is low, give oxygen, IV fluids, heparin 5,000 units immediately, and over 24 hours you have to give 30,000 to achieve full dilatation, full anticoagulation. Now, if there's a clot, then you have to use streptokinase or alteplase, which is 100 milligram intravenously in 2 hours. If there is an imminent risk of cardiac arrest, because she's finding it difficult labored breathing. Alternatively, if it is not working, then you have to do a pulmonary embolectomy, and unlike open thoracotomy procedure. So you identify where the clot is and you pass on the catheter. It's usually a multi-purpose catheter, and this is the latest one people are using called the Thrombolex Bashir pulmonary catheter. So it is in a collapse state, it goes through the clot and you twist with the small wires, and also there is clot lysis drugs can be given, and you break up the clots, and then it might go into the distal segments. but it'll be small emboli. So we go to amniotic fluid embolism, which is rare, and the cardinal features are hypotension, hypoxia, and coagulopathy after she recovers. And usually she goes into a trance-like situation, unconscious for a short time, or she's gazing, and then suddenly she collapses. There's a diminished left ventricular function, increased pulmonary trunk pressure, and there's a sudden collapse. And usually it's like an anaphylaxis. That's the commonest presentation. And some would call it anaphylactic syndrome of pregnancy instead of amniotic fluid embolism. So acute hypoxia is a feature. You have to give oxygen, acute rise in pulmonary pressure with right ventricular failure, and severe DIC afterwards. So you have to be prepared for a massive postpartum hemorrhage. If survives the onset, majority die within 1 hour. So even after resuscitation, they can die. Usually it's a postmortem finding, but nowadays we identify milder forms. So you have to give the support to the lungs, the heart, and the IV fluids. And once coagulopathy sets in, you manage and she will survive. The Royal College guidelines indicate that the management is supportive and specific. There's no proven effective treatment. Early involvement of senior experienced staff, including midwives, obstetricians, anesthetists, hematologists, and intensive, essential to optimize outcome. Coagulopathy needs early aggressive treatment, including the use of fresh frozen plasma. Now, they are given a warning about using recombinant factor 7A. Should be used only if coagulopathy cannot be corrected by massive blood component replacement, as it causes poorer outcome in women with amniotic fluid embolism. So first you have to try the fibroid, the practice, the platelets, and so on, before you embark on practicing. Move to eclampsia. The incidence of eclampsia in the UK has come down tremendously. It's 4.9 per 10,000. So in other words, you might get 1 in 2,000. Very rare, because they are good antenatal care. The hypertension is picked up, or if they have symptoms, they are picked up and they are transferred and they get treatment, so they don't get the eclamptic convulsions. 30% of all fits occur postnatal with minimal signs of prodromal preeclampsia. So we get caught without the blood pressure looks normal, but then suddenly shoots up and she has a fit. Treatment is IV magnesium sulfate, but we have to be careful. Wherever we are using magnesium sulfate, toxicity can arise, and therefore you must have 10% calcium gluconate, 10 milliliter, or calcium chloride 10%. Give IV slowly. Eclampsia should be managed in accordance with the NICE guideline, which is given, which is magnesium sulfate, and also reducing the blood pressure to normal levels. Now, the causes of death due to eclampsia, preeclampsia, has been studied over the years, and cerebral infarction or bleeding seems to be the major cause, followed by pulmonary, hepatic, and others like renal is very small. So these are the numbers, and we have to be careful about imaging. Should we do an imaging if she has a convulsion? If it is atypical eclampsia, you're not expecting, or if it is 48 hours after delivery, she has a convulsion, or less than 20 weeks, or she's in coma for a long time, or she has focal neurological symptoms, or difficulty in controlling blood pressure, then that might be due to a bleed. So it might be an AV aneurysm, which is ruptured due to the rise in blood pressure. So you have to do an imaging. But if it's a standard eclampsia, just because the blood pressure goes up and she has a throw or fit, doesn't need regular imaging like a CT or an MRI. We move to septic shock. Initial signs can include tachypnea, tachycardia, change in mental status, and should be suspected in all cases of collapse associated with or without temperature. So it doesn't need to have temperature. Septic shock should be managed in accordance with the Surviving Sepsis Campaign guidelines. Obstetric causes metritis, retained plaques, and infected hematomas, but there could be non-obstetric causes like pyelonephritis, cholecystitis, and these are more likely to lead to septic shock in obstetric. And it may be associated with DIC and thrombocytopenia, so we have to be careful how to deal with coagulation problems in septic shock. May proceed to adult respiratory distress syndrome, so you need a hematologist to manage the coagulation, a pulmonologist or respiratory physician or an anesthetist. And profound hypertension can happen because the metatarterial sphincters are damaged, there's pooling of blood in the capillary bed, and they can end up in renal failure. So you might have to consult the nephrologist as well. So the treatment is early broad-spectrum antibiotics after blood culture. So you put a large bore cannula, 14 or 16 size, take blood for aerobic culture, anaerobic culture, and start with broad spectrum to cover the entire spectrum. So for gram-negative and bacteroides, we give metronidazole or flagyl. And gram-negative, we cover gentamicin as well. And gram-positive, we give cephalosporins because it has less side reaction. So we give cephalosporins, gentamicin, and metronidazole. Then vigorous fluid replacement, which is 60 to 80 ml per kilogram body weight within 2 hours. So that's the amount of fluid she needs. And if it doesn't, blood pressure doesn't come up, you have to start giving inotropes. So you need circulatory support. And you might need ventilatory support with an incentive. You have to give high flow oxygen. Now, rarely she might need renal support. If the potassium level goes up, then you have to measure the electrolytes. And if potassium goes up, then she needs some insulin and glucose to dry the potassium and need temporary dialysis process. So initial treatment with broad spectrum antibiotics after blood cultures is the key. And once she is in septic shock, every hour you don't give the broad spectrum antibiotics, the chances of survival drops by 6%. So it can be 20 to 60% mortality in septic shock if you don't manage her early. Consult the microbiologist because in that particular hospital, some other organism might be more predominant. So you have to know what is the best antibiotic to give. Specific antibiotics once the organism is identified on culture. And rigorous search for possible source and surgical removal because you can't treat septic shock or severe sepsis if there is infected products in the uterus. You have to clean that. If there is an abscess, you have to drain it. And then only the antibiotics and the IV fluids and blood will work. We move into local anesthetic toxicity. Local anesthetic toxicity is suspected. If it is suspected, you have to stop injecting. Like when you're giving lignocaine accidentally, it has gone intravenously, or you're giving epidural, it becomes a dural and gets into a vascular system. She can show signs of sudden freezing and difficulty in breathing. There you have to give a lipid rescue should be used in case of collapse, secondary to local anesthetic toxicity. So there is a solution, intralipid 20%, should be available in all hospitals, and that should be given. And cases of lipid rescue should be reported to the National Health Service improvement and the lipid rescue site. So in summary, the principles of critical care and postpartum collapse is a multidisciplinary approach is essential. The pregnant patients have an altered physiology from non-pregnant patients, cardiac output, heart size, systemic vascular resistance, circulating volume, coagulation, lung function, blood gases, renal function, electrolytes, hemoglobin is low, and increased oxygen consumption. So there's a need for a midwife and obstetrician to be involved, followed by an anesthetist and respiratory physician and intensivist and so on. The second, so first is multidisciplinary care. Second is monitoring. Monia is I warn. And you have to immediately start plotting the physiological variables like blood pressure, heart rate, CVP, urine, temperature, blood gases, hemoglobin, potassium, etc. So you must have a chart where you can have a trend of physiological variable. What happens at 3 o'clock, 3:30, 4 o'clock, 4:30? In a collapsed patient, is the hemoglobin dropping and dropping? Is the potassium going up? Is the heart rate going up? And so on. So it'll be like this. You will have a trend of physiological variables. The graph shows how the heart rate is going up and the blood pressure is coming down. At the end of 4 hours, it is almost equal, cutting each other's shock index is 1. And then you look at the hemoglobin, it is dropping from 10 to 6.2 over the time, and urinary output is dropping, so you know there is a problem of bleeding, which causes a rise in blood rate, drop in blood pressure, and drop in hemoglobin. Now, this is better depicted by chart, which is called the early warning obstetric score chart. And as I mentioned, if you look at it very carefully of rule of 30, you mind a 30% increase will shift that into red. So here the temperature and so on is given. And if you look at the heart rate, if it is 90 to 110, it's amber, over 110 it is red. Similarly, respiratory rate 20 to 24 is amber, and over 25 is red. And here the systolic blood pressure is plotted differently from diastolic blood pressure because the same chart is used for preeclampsia as well as postpartum hemorrhage. So if the systolic blood pressure drops below 90, it comes into the amber, below 80, it becomes in red. Now, if she was a hypertensive patient, then if it goes to up to 160, it's amber, and over 160, it is red. So we plot the diastolic separately, as you could see here, and if the diastolic drops to below 50, that is red, and if it is diastolic goes up to over 90, it's amber, over 110, it becomes red. So the obstetric early warnings card, where you have to be worried, is given on the right side. What is the bad parameters? And if there is one red or two yellow, then the junior doctor and the midwife can escalate, saying there are two reds on the chart, or two amber and one red, and please come and see. Because many of the maternal deaths in the UK are because the junior doctors and midwives didn't know the seriousness of the condition and did not inform the clinician. And inform the clinician should be in an organized way, using a chart like an ISBA, identifying situation, background assessment, and recommendations. You identify Dr. So-and-so from the labor ward. The situation is this: the patient, this is the respiratory rate, temperature, blood pressure, and about the loss of consciousness. This is the background. She is so many years old, the fourth baby, and collapse. And assessment: this is what I think has happened, and this is what I like to do, and what is your recommendation? In terms of other, so we said multidisciplinary care, observation is number one, continuous observation. Number three is define the current abnormal physiology and correct. So you have to correct, and the pulse rate is high, you have to give more fluids, blood pressure is low, you have to give blood, correct any electrolytes. Number four, see cause of the disease process and institute definitive treatment, like whether it is needed to give some anticoagulants, whether antibiotics, whether you have to drain the abscess, and so on. Number five, anticipate and prevent, if possible, the disease progression. So if you know already things are getting worse, then you must prevent and support the failing system. So if the respiration is not working well, you have to give ventilation. If the kidney is not working well, hemodialysis, and so on. And of course, you mustn't forget the pastoral care to patients and relatives. Once the patients are recovered, you have to talk to them, and relatives, you have to talk when the patient is unconscious. So what does the ongoing management consist of based on these principles? So senior staff with appropriate experience should be involved at an early stage. Transfer should be supervised by an adequately skilled team with appropriate equipment. In the case of maternal collapse, secondary to antepartum hemorrhage, the fetus and placenta should be delivered promptly to allow control of hemorrhage. And in the case of massive placental abruption, C-section may be occasionally indicated, even if the fetus is dead, to allow control of hemorrhage. Intravenous tranexamic acid significantly reduces mortality due to PPH. Neuroradiologists and neurosurgeons should be involved in the care of pregnant women with intracranial hemorrhage at the earliest of. In case of anaphylaxis, all potential causative agents should be removed and resuscitation. Anaphylactic reaction occurs in the community. If it happens, then the woman should have basic life support and transferred to the hospital. And suitably trained healthcare professionals should be present, in which case you can, with the appropriate equipment, they can resuscitate in the periphery itself. And the treatment for anaphylaxis is 1 in 1,000 adrenaline 500 microgram, which is 0.5 ml IM. This dose is for IM use only, so that is for anaphylaxis. So in summary, who should be the team? A general arrest team, senior midwife, obstetrician, obstetric anesthetics, and as necessary, you can involve the intensive cardiologist, bacteriologist, surgeon, and radiologist. The most senior obstetrician and time of the cardiopulmonary arrest call. The neonatal team should not be forgotten. If the baby is viable over 24 weeks, then we call it 22, but country to country can vary. Where the woman survives, a consultant intensivist should be involved as soon as possible. And clinical governance measures should be taken into consideration to improve care, which means accurate documentation is essential. And all cases of maternal collapse should generate a clinical incident form So we can study from what happened, and this should be reported. If she dies, usually inquiry team in the UK. And all generic life support training should consider adaptation of cardiopulmonary resuscitation in pregnant women. So when we train for general CPR, we had to add an additional component for pregnant women. All maternity staff should have a formal multidisciplinary training on generic life support as well as for pregnant mothers. Life support training improves resuscitation skills. Small group multidisciplinary interactive practical training is recommended to improve management of maternal collapse, and debriefing is recommended for the woman, the family, and the staff involved. So in conclusion, maternal collapse is a rare event, not well managed, will be a near miss or a miss, and we can and should avoid near miss and mortality by monitoring, starting treatment early. Outcome for mothers and babies with maternal collapse depend on the cause of collapse, gestational age, access to emergency care. And survival rates are poorer if the collapse occurs outside the hospital. And in maternal cardiac arrest, survival over 50% is reported. So it's not a case to just forget, but we have to try our best to save at least 50% or more. And I put this as 7 C's, which as individually we have to develop in terms of maternal collapse. You must have the commitment to run to the place very immediately, and compassion to the patient and relatives, communication, confidence, competence. Confidence and competence comes in with training, companionship, teamwork. So you have to get hold of a multidisciplinary team. And you have to have a helicopter view, like a commander, and tell Susie, you do that, John, you do this, and give commands, because a number of things has to be done. And continuity of care has to be maintained, because many of these women will long-term problems with blood pressure, hypertension, so on. So you have to really manage. So I would like to thank you for Chowdhury. It has a number of good chapters, which I would recommend for you to read. So I'll stop there, and I'm happy to answer any questions. Thank you.
Thank you so much, Sir Sabratna Murulkumaran, for taking the pain and joining us virtually in these early hours from UK. So may I request our chairperson, Professor T. Choudhury sir, to please say something on his talk.
What can I say after that elaborate lecture on maternal collapse? First of all, I would like to congratulate the RCOG for bringing out this green top publication this year, and to Professor Urulkumaran to highlight some of the findings and recommendations from that publications, and also adding his own experience. The problem is that we do not know what is the incidence of maternal collapse. Admittedly, it is not very high. I tried to find out the literature. There is 10 times variation in the incidence quoted. So naturally, we are not sure, but definitely it is more in developing countries compared to where Professor Urulkumaran is working now. So I think this is a very topical topic which has been revisited, and rightfully so. In spite of knowing many things about resuscitation, we find that when such an accident happens in the labor room, everybody becomes perplexed. Even the senior-most person doesn't know what to do actually. So everybody waits that this is a multidisciplinary team should take over the patient. But when that multidisciplinary team will come or will be able to assemble, in developing country situation, we often do not know that. So I was just wondering that in case of cardiac arrest, most of the hospitals has got a code which can be activated so that the whole team rushes to that particular spot. And this is, maternal collapse is also one condition which should have a code. And it should be activated so that all the people can be together at the shortest possible time. In case of maternal collapse, you know time is the essence. More time you lose, the less is the chances of the patient to come back. So early resuscitation is extremely important. And simple resuscitation is easily available everywhere. Any MBBS doctor will be able to do that. But in case of pregnancy, situation is a little different. Their physiology is different, anatomy is different. But putting a simple wedge on the back or keeping the airway clear by mechanical suction, changing the position of the patient, giving oxygen, these are minor measures which can be done everywhere till the team comes for the proper resuscitation. But I think I have seen many patients or many units become completely perplexed when such an accident occurs and there is masterly inactivity, nothing doing till the team arrives. So this should not be the approach. Approach should be whatever is possible in that situation, it should be done as early as possible and with the minimum amount of trauma or damage to the patient. And as Professor Olukumaran has said, that these patients, because of physiology, they go into shock easily, and resuscitation also is more difficult. Because, for example, you cannot give an effective cardiac massage in a pregnant woman undergoing collapse because of the large uterus. You cannot sometimes inflate the lungs because of the large uterus there, say in case of a pulmonary amniotic fluid embolism. And so there are lots of impediments. But in spite of that, lots of improvement has also been made, and many of these patients who would have been dead in any case are now surviving because of timely multidisciplinary resuscitation. So that should be our aim. When a patient undergoes collapse in the labor room, we should attend as early as possible as a multidisciplinary team, give preliminary ABC treatment of resuscitation, and get the team or gather the team as quickly as possible. Early resuscitation not only will save the patient, but in many cases also prevent post-recovery neurological symptoms. So I think this is a very topical subject which requires attention because number is not more, but the patients who suffer from it really deserve an effective treatment. So thank you very much, Professor Olukumaran, to give this insight into this one of the serious complications of pregnancy and labor. Thank you again.
Thank you so much, sir, for your invaluable remarks. We have come to an end of session 3. Now it's time for the book handing over ceremony. May I request Professor Firoza Begum, President, Maternal Fetal Medicine Society of Bangladesh, to please come up in the dais. And she will be handing over her book on high-risk pregnancy for postgraduate students, published by JP Brothers, to our chairperson, Professor T. H. Choudhury, sir.
Honorable dignitaries, learned audience, distinguished guests from home and abroad, Assalamu alaikum and good afternoon to you all. I am Dr. Fahmida Shamin Jyoti. I am Dr. Raunak Jahan. Welcome you all in the fourth session of our second International Scientific Conference of Maternal Fetal Medicine Society of Bangladesh 2022. Our current session is on fetal growth restriction, which is an attention-grabbing issue in the journey of managing high-risk pregnancy.
This session has two parts. In the first part, there is keynote presentation, and in the second part, there will be exciting panel discussion. For the first part, we have two chairpersons. I am very glad to announce the name of our respected chairperson, Professor Dr. Shikha Shaha Madam. She is President OGSB Borishal Medical Branch and ex-head of the Department of OBGYN Borishal Medical College. And Professor Shikha Ganguly Madam, she is working as head of the Department of Maternal Fetal Medicine Unit, Dhaka Medical College Hospital. My humble request to chairpersons to come up the dais and be seated. Dear audience, you will be delighted to know the name of the speaker of this session. He is Professor Arijit Biswas from Singapore. He will speak for 20 minutes on his topic, that is fetal growth restriction, optimizing management. And we have a panel discussion session in the second part that will be moderated by fetal medicine specialist Dr. Anita Kaul from India. And we have 6 panelists who are very well renowned in our country. Professor Afzal Nasser Chaudhuri, ex-professor OBGYN Shahid Sohrawardi Medical College, Dr. Noor Nahar Khanum, Associate Professor, Bangabandhu Sheikh Mujib Medical University, Professor Muna Selima Jahan, Professor and Head of Maternal Fetal Medicine Department, Sir Salimullah Medical College, Dr. Jubaida Sultana, working at Shahid Sohrawardi Medical College, and Dr. Jannatul Firdaus, she is President OGSB Khulna branch, and Dr. Nargis Fatima, she is working as Senior Consultant, Square Hospital. Now I am requesting our respected chairpersons to conduct the session. Madam, please.
Good afternoon, ladies and gentlemen. I humbly request Professor Arijit Biswas come up on the stage to present his presentation. Now I would like to introduce Professor Arijit Biswas, MBBS, MD, All Institute of Medical Science, MD, National University Singapore, FRCOG UK, Fellow of Academy of Medicine, Singapore, Senior Consultant, Division of Maternal Fetal Medicine, Clinical Director, Department of Obstetrics and Gynecology, National University Hospital and National University of Singapore. His special interest is in the areas of prenatal diagnosis, antenatal ultrasound, and high-risk pregnancies. Please come up, Professor Arijit Biswas.
Can you hear me? At the back? Thank you, Madam Chairperson, for your kind introduction. I must first start by thanking Professor Firoza Begum and also Professor Tabassum Parveen for inviting me once again to Dhaka. I'm so glad to be here and seeing so many familiar faces as well as new faces and a whole room full of people who are here to participate in this fantastic meeting. Thank you very much. I won't spend much time talking on that. Let's move on to the topic. I will be talking on fetal growth restriction, optimizing management. Just a few, have you got a pointer? And there's a few photos of our hospital. I can't help a little bit of boasting. It doesn't move. previous one. Okay. I've been associated with National University of Singapore for the last 31 years. I've been teaching there. And I've seen how it has grown. Our university has, in clinical and health sciences, in the Times Education University ranking, is now placed at 17th position between University of UCLA and University of Pennsylvania. So we have achieved this with hard work, and we hope we will maintain and go even further higher up in this ranking. So sorry for the boasting. Okay, let's start on with the topic. I give you a situation. How do we manage? How do we manage this 28-weeker, normotensive, estimated fetal weight about 800 grams, which is below third centile, and there is absent umbilical artery and diastolic flow? Would you deliver or wait? Those who know the answer to this confidently, they can go to sleep. They don't need to hear. But if you are unsure about this, let's get on with it. So first thing, let's get the definitions correct. SGS, small for gestational age, a fetus that has not attained a specific biometry parameter threshold for the given gestational age. Most accepted definition is the estimated fetal weight below 10th percentile. The perinatal mortality and morbidity significantly goes up once it is below third centile. So SGA, we take it as less than 10th centile. Now, smallness is not sickness. Not all small babies are sick. Roughly about 30%, less than 1/3 of SGA babies are true FGR, or fetal growth restricted babies. The rest, 70%, are not the true FGR babies. They're mostly constitutionally small babies. Like as I always tell my patients, my 5 fingers are not the same size. That does not mean that little finger is bad or has a problem. It's a bit small, that's all. So same thing, smallness does not always mean sickness. FGR, true growth restriction, represents a pathological condition associated with adverse perinatal outcome, whereas the constitutional SGA babies are near normal perinatal outcome. So we have to be clear with that. I can also divide them as these are placenta mediated. The FGRs are placenta mediated, and the constitutionally small are non-placenta mediated. Yes, there is a small number of them will be what we call fetopathic small babies. Due to infection, genetic syndromes, yes, there will be a small number in that non-placenta mediated small babies would be, thank you, that's better, would be small as well. Previously, we used to say asymmetric and symmetric growth restriction. If it's asymmetric, it's possibly placenta-mediated true growth restriction. That's not true. Many true FGR fetuses are asymmetric, but many are not. You cannot use symmetrical and asymmetrical growth to differentiate between the pathological FGR versus constitutional FGR. So the real management of fetal growth, I break it in 3-step strategy. First, you need to detect, prenatal detection. Number 2, once you have detected, correct surveillance, and ultimately, the right timing of delivery. These are the 3 steps in the management. And the questions we ask, first, as I said, is this true FGR? Which assessment tools to use? Do we need to deliver it now? How to monitor? And exactly when to deliver. Now, this depends on gestation and stage of fetal growth restriction. I'll come to that. And a little bit revising of the pathophysiology of the placenta-mediated growth restriction. So initially, it starts with increased uteroplacental vascular resistance, secondary to villus infarction, damage, or death of villi. As Pooja in the morning was presenting, you all saw that. It results in increased umbilical artery Doppler indices. You saw that SD ratio was increasing. Very nice cartoon Pooja showed in the morning. So this results in lack of transfer of nutrients, low substrate supply, resulting in the smaller size, the small baby. ultimately low oxygen transfer, leading to fetal hypoxemia. Then the fetus adapts to it, fetal vascular adaptation. You have, by decreasing resistance in the CNS to protect the brain, so brain, the middle cerebral artery flow increases with the decreased resistance in the brain, decreased renal perfusion, less urine output resulting in oliguria and oligohydramnias. And finally, it goes to decompensation, CNS and myocardial hypoxia of the baby. So the brain and the myocardium both are now affected by hypoxia, resulting in abnormal ductus venosus waveform changes and also CTG changes. You will see at that when it's decompensating. And that's when you know it's pre-terminal. So I will spend a little time, if you don't mind, on Doppler. What is Doppler ultrasound? This is the biggest, the most important tool we have now in assessing the baby, the placenta, yeah, and its adaptation. So what is Doppler ultrasound? Understand that this phenomenon, the physical phenomenon, that if you send a sound down to a moving object, here we are examples of moving red blood cells. If there is an incident beam with a certain frequency, goes and strikes that and comes back, the reflected beam, the frequency changes. The frequency changes. You know, the sound, if it's like a moving train coming into the platform, you can see as it moves towards you and passes from you, the frequency changes. Similarly, there is a frequency change, what you can get, the transducer receive. And this frequency change is called the Doppler shift. And it's dependent on certain things, you know. I will come to that. Basically, the frequency change depends. You don't have to remember the equation and all that, the Doppler equation. These are taught in physics in school. But basically, it depends on the velocity of the flow, of the RBCs which are flowing. The velocity of the flow is important. And if you can maintain the angle that your Doppler beam hits the moving red cells in a 0-degree angle, means directly like that, as was shown in the image, then the Doppler frequency shift very much reflects the velocity of the blood flow. So you can actually, from the frequency shift, you can derive the velocity. That is the main physical phenomenon which we use in Doppler ultrasound. And what is done in the spectral Doppler, as we see in the so-called waveforms which we see, basically with time, how is the frequency changing, the frequency shift? So here, the top of that peak is with systole. The flow was highest at that time. Goes down with, this is the time, this axis. Goes down, in diastole it has come to the bottom. Now this waveform, we are very familiar with this. Now if you look at that it depends on, reflects two things, the velocity and the pulsatility of the vessel. And this depends, the pulsatility of the flow, so you know, we get two information. One is the velocity, how much is going out, that is one thing. And second is pulsatility, how much is opening and closing with systole and diastole, the vessel. And that depends on the downstream resistance or impedance. For example, if you are looking at, as Pooja was showing you in the morning, umbilical artery, you are looking at downstream resistance into the the placental villus tree. Because that umbilical artery will be going into small villi and vessels there, right? So if those are blocked and damaged or narrowed, this pulsatility will go up. The diastolic flow will keep going down. So this is what we utilize in Doppler ultrasound. Now if you look at that, what does it say? This is just a cartoon showing the intervillar space, and this is the villi with the villus artery. This is the spiral arteriole, which is bringing in the blood into the intervillar space. Now, when we look at uterine Doppler, what are we looking at? We are looking at adequacy of the uterine flow into the uterus. So this side, the spiral arteriole, is it bringing blood adequately? That's what uterine artery Doppler is showing us. Umbilical artery Doppler, what is that telling us? As was mentioned in the placental villus blood flow integrity, venous blood flow, this side. That's what he's looking at. And when we look at intrafetal Dopplers, we're looking at the baby's middle cranial, we are looking at adaptation, how the baby is adapting to, say, lack of oxygen. When is it opening up his middle cerebral arteries, protecting his brain? That's what we are looking at when we do a MCA Doppler, intrafetal Doppler. Now, this is typical. Now understand, the placental circulation is a very low resistance circulation, and the resistance goes down as the pregnancy advances. So there is usually a huge diastolic flow. So umbilical artery resistance index, all these indexes, don't worry about this. This is RIPI. What they are telling you is, as I told you, the pulsatility of the flow. How pulsatile? Higher the resistance index, RI, means higher pulsatility of the flow, lower diastolic flow, right? So umbilical artery RI or PI is one of the lowest in the fetal circulation because it is the most low resistance circulation. So once it starts going up, as pregnancy progresses, that's not a good sign. It should normally, the RIPI or the systolic diastolic ratio, whatever way you look at it, should be going down as the pregnancy advances. If you look at that, go back to the same thing again, this diastolic flow, as Pooja was showing, will touch the bottom and even get reversed when at least 80% of the villi are damaged. Not until then. When it has reached 80% of the villi have gone, all the arterioles are all damaged, then you start seeing absent end-diastolic flow. Until then, you'll see gradually the diastolic flow is decreasing, your pulsatility increasing, the resistance is increasing. But once about 80-85% is gone, then you see the absent end-diastolic flow. The middle cerebral artery, on the other hand, the flow resistance should always be higher than the umbilical artery PI at all times. This is something, I know there are a lot of things in the books, St. George's, Asma Khalil has published a lot of things on it, but let's keep it simple. The MCA over umbilical artery PI should always be greater than 1. Just remember this, should always be greater than 1. Because if it is greater than 1, that baby is not compensating. The resistance of the middle cerebral artery is not lower than the placenta. Once it gets reversed, that means the resistance in the brain is lower than the resistance in the placenta. That's the problem. Baby is adapting. And I'm not just telling one like that, because if you see this distribution of middle cerebral artery across gestational age, you will see that the lower line, it's around 1. So it's always above 1, the CP ratio. So if it goes below that, that's problem. That's problem. That shows baby is adapting to hypoxemia. So basically, there is circulatory redistribution going on, and we can pick up from the baby is shunting blood to the brain, to the heart, to the adrenals, and away from the body, from the carcass and the kidneys. And that's how the MCA is to be measured. You can see there's a middle cerebral. It's very easy to, anybody who has done a little bit of practice with ultrasounds is very, very easy to do the MCA. I do in my practice, every woman after 32 weeks, I see in the clinic, will have an umbilical Doppler and MCA bedside in the clinic visit every time. And I can tell you my clinic, Mahesh will tell you I see at least 50 patients in the morning in my clinic. And I can do it for each patient I do and document. It is not difficult if you start practicing that. And it helps, I can tell you that. So CPR less than 1 suggests compensatory changes in the fetus. So when is a SGA baby truly FGR? Now let's come to that. FGR is diagnosed when SGA means less than 10 centile estimated fetal weight is combined with any of the following: abnormal umbilical artery Dopplers, abnormal MCAPI, means too low MCAPI, too high. More important, abnormal CP ratio. I will stick to that. Abnormal CP ratio is less than 1. Or abnormal uterine artery PI. Or if the estimated fetal below 3rd centile. Any one of them it fulfills, that is an FGR baby. Let's keep that simple. It'll make life much easier if you do that. Now, it's not, I'm not bringing it from the top of my head. This is based on data. This is based on data, which shows that for control, if you look at the incidence of C-section for fetal distress and neonatal or neonatal acidosis, for controls, it was about 8% was the incidence. If any one of the, control means SGA baby without any of the features. If there's any one of the features, it goes up to 11%. If all three are abnormal, means it's a less than third centile baby with raised uterine artery PI with an abnormal CP ratio, the incidence of this goes up to 40%. 4 out of 10 babies will have either C-section fetal distress or there will be neonatal acidosis. So using this criteria for the definition of FGR is valid. Of course, I just want to touch on if it's a very early onset severe growth restricted baby with normal umbilical artery, uterine artery flow, it has to be sent for genetic counseling. We will do that. We'll need some either cardiotyping, depending on what to say, CMA, whole genome sequence, whatever. We need to rule out infections, CMV, toxo, malaria, syphilis, and of course, even thrombophilias, if there's very early onset, severe SGA. Now I will come down to the management of it. The management should be, now in this day and age, should be stage-based. What stage of FGR are we looking at? Dopplers, as I told you, helps in assessing the severity of FGR. But do not deliver just on the basis of abnormal Dopplers. You will just convert stillbirths to neonatal deaths. Stillbirths to neonatal, or severe long-term morbidity. So gestational age is an important determinant of perinatal survival. So it comes back to the question I started. Should you deliver immediately a 28-weeker, 800-gram baby with absent EDF in umbilical? Should I just go and deliver? Answer is no. I will tell you currently what practice we are doing. So let's take, what is stage 1 FGR? Stage 1 FGR is when it has fulfilled the criteria of diagnosis from those 3 things which I told you. Less than third centile weight, uterine